Hello, everyone, and welcome to our module on cystic fibrosis. Cystic fibrosis is an inherited genetic disease, and it's passed down from parents to children in an autosomal recessive fashion. This means that in order to have a child affected with cystic fibrosis, both parents must be carriers of one of the cystic fibrosis gene mutations, and we'll talk about those in just a minute. The result of this genetic disorder is thick, sticky mucus in the lungs and the GI tract. And for this reason, cystic fibrosis is a common cause of chronic lung disease in children. CFTR stands for the cystic fibrosis transmembrane regulator, and this is the name of the protein that's abnormal in cystic fibrosis that leads to the clinical features of the disorder. And the CFTR gene, which is found on chromosome 7, is what's abnormal in cystic fibrosis. This codes for the abnormal protein. The CFTR is an ATP-gated chloride ion transporter. So what does this mean? This means that it's a transporter of the ion chloride, and in order to move chloride in and out of cells, it uses ATP. That's why it's called ATP-gated. And it has different functions in different cell types. First, let's talk about the functions of the CFTR in epithelial cells, especially in the lungs and the GI tract. So in these locations, what the CFTR does is it secretes chloride out of epithelial cells via an ion channel. This is a picture of how it works right here. This is the CFTR. It pushes chloride out of the cell. It also has a second function that's very important in epithelial cells. It inhibits the ENaC. The ENaC is an epithelial sodium channel that's found in a number of places. And so because the CFTR inhibits this channel, it causes less sodium uptake. So what this means is the net result of these two functions of the CFTR in epithelial cells is that it moves sodium chloride out of the cell. And so when you move sodium chloride out here, outside of the cell, what's going to happen? Water is going to be drawn out as well. And so this is how the epithelial linings of the lungs and the GI tract keep themselves hydrated, by using the CFTR to push sodium chloride out of the cell, which will be followed by water. So in cystic fibrosis, when the CFTR doesn't work normally, what happens is the secretions become abnormally thick. That's because there's less sodium and chloride moving out of epithelial cells and therefore less water following out of the cells onto the mucosal surface. In sweat glands, the CFTR has opposite functions compared to what we just talked about in the last slide for epithelial cells. So in sweat glands, the CFTR reabsorbs chloride from sweat and it increases ENaC activity so that more sodium gets removed from sweat. As a result, sodium chloride gets reabsorbed because of the CFTR by glandular cells, and sweat becomes hypotonic, meaning it has a low level of sodium chloride in it because of the CFTR. This means that in cystic fibrosis patients where the CFTR doesn't function normally, they have higher amounts of sodium chloride compared to normal in their sweat. And this is one of the ways we make the diagnosis of cystic fibrosis. It's called a sweat test, and we'll talk about it later. There aren't really clinical consequences of more sodium chloride in the sweat, but this is a very important feature of cystic fibrosis used for diagnosis. And then finally, in renal epithelial cells in the kidneys, the CFTR, through a complex mechanism, promotes the secretion of bicarbonate so that bicarbonate goes out in the urine, and it promotes the reabsorption of potassium so that potassium is pulled from the urine. And it's important to understand these two effects because metabolic alkalosis with hypokalemia is a common problem in cystic fibrosis patients, especially in the setting of heat stress. So with heat stress, for example, if a person is outside on a hot day, they will lose volume because of sweating. But as we just discussed, cystic fibrosis patients have more sodium chloride in their sweat compared to normal. So they have even more volume contraction than the typical person. So they have a significant volume contraction when they have heat stress. This is much like a person who takes a loop diuretic. In addition to this, patients with cystic fibrosis lose some potassium in their sweat. And then because they don't have these renal epithelial cell functions, they lose bicarbonate secretion in the nephron. So more bicarbonate is retained, and they don't reabsorb potassium, so potassium gets wasted in the urine. So take a second to get this straight in your mind. I know it's a little bit confusing, but the net result of all these things I described here is that patients who have cystic fibrosis, if they have heat stress, can develop metabolic alkalosis with hypokalemia. They're going to present with a high bicarbonate because they're not secreting bicarb as they should, and a low potassium because they're not reabsorbing potassium like they should. Okay, let's talk about some of the gene mutations that can lead to cystic fibrosis. So the first thing you should know is that there are many different mutations that have been identified and described. but the most common mutation is called delta F508. This mutation involves a deletion of 3 DNA bases that leads to a frame shift mutation where there's a shift in the reading frame of DNA. And I talk about this type of mutation in detail in videos in the genetics section. And this mutation involves a gene that codes for the 508th amino acid in the CFTR protein, and that amino acid is phenylalanine. And because of this, it's called the delta F508 mutation. The most common consequence of this mutation is abnormal processing of the CFTR protein. Usually it's abnormal protein folding, and this prevents the protein from being trafficked to the correct cellular location. And as a result, the CFTR is absent from the cell surface, and that leads to all those things we just talked about on epithelial cells in the last few slides. Okay, so now let's talk about the pathophysiology of cystic fibrosis in terms of what happens at an organ system level. And we'll start by talking about the lungs. So in the lungs, all that thick, sticky mucus leads to recurrent pulmonary infections. It's hard for the cilia to move mucus out of the lungs and to move bacteria out of the lungs. And so recurrent infections occur, especially with Pseudomonas and also Staph aureus. And we'll talk about these bacteria later in this video. Beyond this, the mucus being thick and sticky can lead to chronic bronchitis, and eventually that can lead to abnormal dilation of the airways, which is called bronchiectasis, and I talk about bronchiectasis in another video in detail. In the GI tract, the thick, sticky mucus impairs the flow of bile and pancreatic secretions, so this leads to malabsorption, especially of fats, because you need pancreatic enzymes to digest fats, and if those enzymes don't flow into the GI tract, that leads to malabsorption. So in particular, children with cystic fibrosis can become deficient in fat-soluble vitamins like A, D, E, and K. They can also develop steatorrhea, which is a type of diarrhea when there's lots of fat in the stool. So later on, we're going to talk about screening. And in the modern era, most children born with cystic fibrosis are identified prenatally through screening. But if children aren't identified through screening, they're usually diagnosed before they're 2 years of age. And they usually have one of 3 different presentations. The first is respiratory disease. This accounts for about 45% of diagnoses. The other 2 ways children are diagnosed are with failure to thrive. This accounts for about 28% of diagnoses. Basically, the children just aren't growing normally because of recurrent infections of the lungs and malabsorption of fats. And then lastly, meconium ileus is another way that about 20% of children are identified. And we'll talk about this in just a second. So for children who are diagnosed with cystic fibrosis because of lung disease, what kind of symptoms do they present with? Well, first of all, they typically have a productive cough. This is because they have thick, sticky mucus that's difficult to clear from the lungs. If you do spirometry testing, they typically have an obstructive lung disease pattern. And once again, that's from obstruction of the airways with thick, sticky mucus. This can lead to hyperinflation of the lungs on chest X-ray, a classic feature of many forms of obstructive lung disease, and that's what's shown in this X-ray right here. Later, as the disease progresses, they can develop chronic bronchitis and bronchiectasis. And then these children are also at risk for ABPA, which is allergic bronchopulmonary aspergillosis. I talk about this disorder in the video on asthma and bronchiectasis, but most cases of this condition, which is basically an allergic reaction to the fungus Aspergillus, occur in children who have either longstanding chronic asthma or cystic fibrosis. So as children grow with cystic fibrosis, their airways become colonized with certain bacteria. Early in childhood, when they're very young, the airways are usually colonized by Staph aureus and non-typable forms of H. flu. But as children get older and into adulthood, patients with cystic fibrosis almost always have their lungs become colonized with Pseudomonas aeruginosa. And so this bacteria is basically going to always be present in these older children and adults with cystic fibrosis. And sometimes the bacteria will grow excessively, and that can lead to an acute exacerbation of lung disease. And so when you're treating acute exacerbations of lung symptoms in patients with cystic fibrosis, the treatment almost always includes antibiotics that cover Pseudomonas, and that's because this bacteria so commonly colonizes the airways of children with cystic fibrosis. Okay, so that's the lungs. Now let's talk about what can happen in the GI tract to patients who have cystic fibrosis. And in the pancreas, you don't have the normal flow of pancreatic secretions, including enzymes that digest fats. So this leads to pancreatic insufficiency. Basically, those pancreatic enzymes, which aren't making their way normally to the GI tract, can begin to affect the pancreas itself. And so this can lead to chronic pancreatitis. And when there's chronic inflammation of the pancreas, eventually the pancreas can burn out and the beta cells stop making insulin as they should, and this can lead to cystic fibrosis-related diabetes. Also, because you don't have those digestive enzymes for fats making it to the GI tract, there can be fat malabsorption. This leads to steatorrhea. So steatorrhea presents as frequent foul-smelling stools. They're often described as oily or greasy, and they can float in a toilet bowl, and that's because they're filled with fat. Fat's not soluble in water, so the stool can float in the toilet bowl. So without the ability to absorb fat normally because of pancreatic insufficiency, children and adults with cystic fibrosis are at risk for deficiencies of fat-soluble vitamins like vitamin A, D, E, and K. This rarely happens in the modern era because we monitor these patients and we administer supplements if they need it for vitamins. But in theory, these patients can become deficient in these vitamins. So you always want to remember this for board questions. A vitamin K deficiency leads to coagulopathy. Vitamin D deficiency leads to a bone condition called rickets. Vitamin A deficiency leads to difficulty with vision, particularly night blindness. And vitamin E deficiency can lead to ataxia and hemolysis. And I talk about all these vitamins in the biochemistry section. I'm just reviewing them here for you briefly because you can see them in patients who have cystic fibrosis if they're not being monitored and supplemented. Okay, meconium ileus is another way that newborns with cystic fibrosis can present. I talk about this condition a lot in the GI section, but I'll briefly review it here. So meconium is the first stool of a newborn, and it's always thick and sticky, even in healthy newborns. But in children with cystic fibrosis, it can be extra thick and sticky, and that can lead to obstruction of the bowel. This is called meconium ileus. Basically, this is what happens when the meconium is too thick and sticky and a plug forms in the GI tract. When GI contents can't move through the GI lumen, this leads to abdominal distension. The baby can develop vomiting. The classic finding on abdominal x-ray is the presence of an air fluid level, which is what's shown here. And basically, the newborn baby won't pass meconium in the first 24 or 48 hours. That's when meconium ileus is present. And once again, I talk about this in detail in the GI section. All right, in cystic fibrosis, you also don't have normal flow of bile because bile secretions are also extra thick and sticky. So what can that lead to? Well, first of all, the bile duct can become obstructed. That means bile won't flow into the GI tract. When you don't have bile flowing into your GI tract, your stools will become pale or clay-colored. That's because bile contains breakdown products of bilirubin, and that's what gives stool its brown color. Also, when bile doesn't flow normally, it backs up into the liver, and this can damage the liver. So you can see elevation of the liver function tests like AST and ALT. The liver can become enlarged. That's hepatomegaly. You can potentially see cirrhosis if this is left untreated, and it also increases the risk of the presence of gallstones. Cystic fibrosis is associated with infertility, so let's talk about that now. So males who have cystic fibrosis, 95% of those patients are infertile. The reason for this is they typically lack a vas deferens. The vas deferens, if you recall, carries sperm out of the testes. So if it's absent, then sperm transport is abnormal. And the reason for this is believed to be because you need the CFTR for development of the vas deferens in utero. So the problem here is sperm transport, not spermatogenesis. Males who have cystic fibrosis can develop sperm normally in the testes. They just can't transport those sperm into the ejaculate. So there are assisted techniques that can be used if males who have cystic fibrosis desire children and want to have normal fertility. Remember, the problem is the transport of sperm, not spermatogenesis. Females with cystic fibrosis also have reduced fertility, although it's not as severe as in males. Problem here is abnormally thick cervical mucus, so this makes it harder for pregnancy to occur. The pregnancy is still possible, and when it does occur, the outcomes are generally favorable, provided the mother has good pulmonary function and is otherwise healthy. Basically, the problem here is the cervical mucus thickens, and that prevents sperm from getting into the uterus and the fallopian tubes and fertilizing the egg. Patients with cystic fibrosis can also develop nasopharyngeal disease, so let's talk about that. Most patients with cystic fibrosis develop sinus disease, and that's because of the same thing we've been talking about, those thick, sticky secretions. They clog up the sinuses. So when you do imaging of the sinuses in patients who have cystic fibrosis, often they are opacified, and that's because they're filled with thick, sticky mucus. This occurs in about 90 to 100% of patients after 8 months of age. And so once the sinuses are opacified and filled with mucus like this, a number of things can happen. First of all, this promotes the development of nasal polyps, which are common in people with cystic fibrosis. This can also lead to rhinorrhea or runny nose and nasal congestion, which can lead to headache and infections and other things. One other clinical feature of cystic fibrosis I'll briefly mention is digital clubbing. That's what's shown here. This refers to an abnormal curvature of the nails. This can be seen in a number of forms of lung disease. It also occurs in cyanotic congenital heart disease. We don't really know why this happens, but it's a common finding in children who have cystic fibrosis. Okay, let's talk about how you make a diagnosis of cystic fibrosis. And so the classic way to make the diagnosis that's been around for a long time is the so-called sweat chloride test. This test is also called pilocarpine iontophoresis. So let's talk about what this means. So pilocarpine is a muscarinic agonist. And when you place it on gauze and put that gauze over the skin, this will cause the skin to sweat. But the way this test works is you put an electrode over the gauze, and then a small electrical current drives the pilocarpine deep into the skin. This is called iontophoresis, and that's why this test is called pilocarpine iontophoresis. This causes the person to begin to sweat, and you collect the sweat on filter paper, and you analyze the chloride content. And as we talked about earlier in this video, a high chloride content of sweat suggests cystic fibrosis. And when you get a positive finding on this test, you can then do a DNA testing and see if the patient has the delta F508 mutation or one of the other common mutations that's already been described. There are rare cystic fibrosis patients who have a negative sweat test. These patients usually have milder disease, but they still have recurrent pulmonary infections and sinus infections. And so sometimes when the sweat test is negative, but there are still lots of infections, we begin to wonder if this could be a cystic fibrosis patient who just happens to have a negative sweat test. So in that setting, there's an alternative to the sweat test. It's called the nasal transepithelial potential difference test. This test essentially measures the voltage across the nasal epithelium, and cystic fibrosis patients have a more negative voltage compared to normal, and that's because of the abnormal sodium processing that we talked about earlier. So if you have a case where you're very suspicious that the child has cystic fibrosis, but the sweat test is negative, this is a backup or alternative test that can be done. Let's talk a little bit about the treatment of cystic fibrosis. So treating cystic fibrosis is an advanced topic. They're not going to expect you to understand it completely at the M1 or M2 level, but they are going to want you to understand a little bit about the mechanisms behind the different treatments that are used. So first of all, for children who have cystic fibrosis who develop exacerbations of pulmonary symptoms, those are usually treated with antibiotics that cover Pseudomonas. And that's because, like I said before, Pseudomonas almost always colonizes the airways of these children by a few months of age. In rare cases, when the disease is unchecked and it progresses and damages the lungs, some children need lung transplantation, but this is less common in the modern era, and that's because we have a number of treatments for cystic fibrosis that prevent the lung disease, and we'll talk about those on this slide and the next couple of slides. So first of all, there are a couple of treatments that promote clearance of airway secretions. One of these is an inhaled drug called DNase. It's also called Dornase alpha, and it basically thins the mucus so that it will move more easily. Inhaled saline is simply sodium chloride in water, and it basically hydrates the mucus so that it will move more easily. And then N-acetylcysteine is another substance that can be used to thin the mucus and help it to move more easily. Beyond those treatments on the last slide that thin the mucus in cystic fibrosis patients, there are a number of newer treatments that are called CFTR modulators. These drugs directly target the CFTR proteins. They increase the chloride ion flux, basically causing what should happen normally from the CFTR protein to occur after treatment with the drug. There are different drugs that are used based on an individual patient's genetics. This is called pharmacogenetics. So depending on which gene mutation the patient has, that determines which of these CFTR modulators you will use in that particular patient. And these drugs can be used alone, or more often they're used in combination. So one of these drugs is ivacaftor. This keeps the CFTR chloride channel open, so it improves chloride ion flux. This can be used as monotherapy, but only in patients who have a specific mutation called G551D, and that's the pharmacogenetics where you have to know the mutation to decide what treatment to use. And then there are the drugs lumacaftor, tezacaftor, and alexacaftor. These drugs can all be used in patients who have the F508 mutation that we talked about earlier, that deletion mutation, and this corrects the CFTR misfolding and leads to more CFTR being on the surface of cells, and that's going to increase chloride ion flux. Once again, the principle here, and something you should know for board exams, is that all of these treatments are based on knowing the pharmacogenetics, meaning knowing the genetic mutation in a specific patient. Some other treatments that can be used in cystic fibrosis are shown in this slide. So pancreatic enzyme replacement. refers to pills that patients can take, and they replace the enzymes that normally come from the pancreas. This helps patients to absorb fats normally. You also sometimes supplement these patients with vitamins, especially the fat-soluble ones like A, D, E, and K. And then lastly, because these children have abnormal mucus in their lungs, you don't want them to get any lung infection. So vaccinations are very important for things like RSV and flu and COVID-19 and anything that can cause a lung infection. In terms of prognosis, the average lifespan is reported as 37 years, but probably this is a low number. That's because those newer therapies, like the CFTR targeted therapies I talked about a few slides ago, have significantly improved survival. But nevertheless, for a long time, death was common in patients with cystic fibrosis before they reached about 40 years of age, and that was usually because of pulmonary complications. The recurrent lung infections would eventually lead to obstructive lung disease that became severe, and bronchiectasis, and if the patient couldn't get a lung transplant, they would die from pulmonary disease related to cystic fibrosis. So I'll finish with one slide on screening, and I mentioned this before, but in modern practice in the United States, most children with cystic fibrosis are identified before they're born because we do genetic testing on the mother. So prenatally, when the mother is pregnant, we can test her DNA for 23 of the most common cystic fibrosis mutations in the United States. Usually the mother is tested first, and if she's negative, then we stop the testing. If she's positive, we can go ahead and test the father as well, because remember, both the mother and the father have to be carriers for a child to be affected. And then if you want to screen a newborn, either because both parents are carriers or because the parents weren't screened, then you can screen the newborn by measuring blood levels of IRT, which is immunoreactive trypsinogen. It's a precursor in the pancreas to the pancreatic enzyme trypsin. And as we've already discussed, in children with cystic fibrosis, there's impaired release of pancreatic enzymes. As a result, IRT is not removed from the blood and broken down through conversion to things like trypsin. So you can test the baby's blood. If it's positive for IRT, meaning the IRT level is elevated, then you can move forward and do a sweat test or a DNA test to determine whether or not the child truly has cystic fibrosis and which DNA mutation they have. And that concludes our module on cystic fibrosis.